Have Michelle Harkins, MD, who will be presenting our APT clinic today.
Great. And so this is a continuation of the Provider Asthma Care Education program that has been sponsored by the National Heart, Lung, Blood Institute. So if you have a question, feel free to interrupt me. And you can mute or unmute your telephone line by pressing, I guess that's a star pound.
Star pound.
All right. And then say your name. I think someone else might have clicked in. Say your name if you want to get CME or CEU credit. I have no disclosures. Okay, so this one picture is it's basically the Physician Asthma Care Education Program, and this was a program that's actually online, so this is the website for it at nhlbi.nih.gov/health/prof/lung/asthma/PACE. So it's a whole program that really is done over a day and a half. And so this is the second kind of condensed version, and we did the first half a couple weeks ago. The guidelines, you can get free copies of the guidelines, and there are little smaller versions or executive summaries, but this is the website to the guidelines that are put out by the National Heart, Lung, Blood Institute. And that's what this is going to kind of try to highlight. These highlights are very brief, and you can get much more in-depth information. In fact, if you want to read the guidelines, they're about 440 pages. So if you're into doing that, go for it. Otherwise, this is a very quick, down and dirty cover of the guidelines. So there's 4 components of asthma management. One, you want to measure the patient and monitor the patient. How are you going to assess them? So we have objective tests, we have physical exam and history findings, and then what we're going to concentrate today mostly on is severity and control of asthma. So grading how severe someone's asthma is, and then ultimately how well controlled they are. That's part of what the providers would do. The other part is the education. There's a huge amount of education involved in asthma care. And if we can educate providers to be able to educate their patients, there's probably a better buy-in from the patients, and there is better outcome data. Last week, or the last visit, we talked more about control of environmental factors and comorbid conditions that affect asthma, and then we'll touch a bit on pharmacology. The key points that we're going to cover in this program, the first 3 is assessment of severity and control. And that really forms the basis of how you decide to treat someone with asthma. Now, what is asthma? It's a chronic inflammatory disease of the airways. It has bronchoconstriction as well as airway inflammation. So you end up having both of these components that cause episodic symptoms of chest tightness, cough, wheeze, shortness of breath. It can happen at night, it can happen during the daytime, it can happen after exercise or after viral colds. So coming up with the diagnosis of asthma was really the topic that we talked about before, and this is really, now that you've made a diagnosis of asthma, how severe is their asthma and how well controlled is it? Point 2, appropriate management requires a proper use of long-term control and quick relief medicines. So most patients are familiar with albuterol or as a rescue med, but there are patients that need to be on long-term controller medications to hopefully not need to use their quick relief medications as often, and this is going to be reviewed through cases today. And because asthma symptoms are really variable, some people cough, some people wheeze, some people have chest tightness, families and patients need to recognize the symptoms and adjust the medications according to a written action plan. So we'll show some examples of that, but it's a roadmap that helps the patients know what to do when they have issues, so that they can take proper steps and hopefully be able to manage their disease better. Points 4 and 5 of this program, we're not going to talk about too much. If we get time, we might. But good communication. between patients and the clinicians, really helps identify the patient's concerns, helps you teach them more effectively, and then the patient can actually have self-confidence to follow the treatment plan. Most of us think we're good communicators, but when you ask patients, they may not think that we're as good of a communicator as we think we are. So making sure that you've addressed the issue and making sure that the patient really gets time to spend to be educated and identify what their concerns are. Maybe they don't want to take an inhaled steroid because they're afraid it's going to boost them up or give them, like the steroids that people use in sports and things like that that are also popular in the news. And that's not true. So it really takes time to identify what the patient's concerns are about the treatment plan. And then point 5 really is that patient education can really be done in several standard primary care visits if you piece it out together. So we've talked about a little bit the diagnosis of asthma, so we're going to spend most of the time talking about the treatment of asthma today. So assessing severity and control forms the basis of the treatment plan. That's our key point 1. Severity is what we usually say is assessed before the patient is actually given treatment. So say someone comes to your office, you've decided that you think they may have asthma, so you're going to grade what severity they are of their disease before you put them on controller medications. Once you've put them on medications and you bring them back, you want to determine how well controlled their asthma is. So control really goes around having an assessment based on patients being treated and how well is that treatment working. It's helpful to have a diagnosis of severity in the chart, and then as they follow up while they're seeing you, how well that asthma severity is being controlled. So severity and control have 2 domains, so impairment and risk. So impairment really is, how often are these patients having symptoms? What is their functional limitations? And then the risk, or how likely are they going to have a bad outcome? An exacerbation or loss of lung function, or they go to the urgent care or ED for exacerbations or have medication side effects. So you put these 2 things into your concept between asthma severity and asthma control. So severity, all patients should have initial severity assessment based on the measures of their current impairment and future risk in order to determine what type of therapy they need. So this is one of the priority messages from the guideline expert panel. So this is the expert panel report number 3. It's still in revision. Potentially there'll be a number 4, but not out as of yet. So this is the asthma severity chart. So components of severity are on the one hand, and the impairment, so symptoms, nighttime awakenings, short-acting beta agonist use, interference with normal activities, and then lung function. So all of these things are what we assess to see how severe someone asthma is. And this is for age 5 to 11. So either you have intermittent asthma or you have persistent asthma. And you have mild, moderate, or severe persistent based on the frequency of your symptoms, the frequency of the nighttime awakenings, how often they're needing their beta agonists, how often their activity is limited, and then what their lung function is if you have spirometry. And spirometry is key in diagnosis of asthma and assessing severity. So as you look at the table across, what I can always tell people is if you can remember the number 2, you've got the table down. So if you have symptoms more than 2 times a week, you're waking up more than 2 times a month, or you're using your short-acting beta agonist more than 2 days of the week, then you probably have persistent disease. And so then how often does that happen? Are you having symptoms daily, or is it like several times through the day? So then that would take you to mild, moderate, or severe, for example. The risk component is at the bottom part, and it's in a little different color, and it's the number of exacerbations requiring oral steroids. So if it's 0 to 1 time a year, that puts you in an intermittent category. If, again, that number 2, more than 2 times or 2 or more times in that year, that puts you in a persistent disease state. So that's how you classify someone's asthma severity. So if I see a 6-year-old that comes in that is saying, I don't really have much interference with my activity, but I'm waking up 4 times a month from asthma, that's going to make that person a mild persistent, even if you don't have the other data. So at minimum, a mild persistent based on that. So that's how you figure out how severe someone is. And then if you drop down at the bottom of the chart, it can tell you what step therapy, and we'll go through that in a minute, of what you need to do for those patients, the lowest level of treatment that you're going to need to start that patient on. Asthma control, again, so you've started them on treatment and you have them come back, and then you review what their level of control is. And it's basically the same things that are in the severity chart. So you want to make sure that the patients are followed up at periodic intervals to assess their control and change the treatment plan if needed. So this is the asthma control chart. And if you notice, it looks pretty darn similar to the other one. So nighttime awakenings, interference with activity, short-acting beta agonists, lung function. There's also a asthma control test that we sometimes use that is not actually on this chart, but that's another marker that can go in there. And again, if you remember the number 2, you've got the chart down. So less than 2 days a week, less than twice a month, less beta agonists needing it less than 2 days a week, then you're well controlled. And so you probably don't need to change therapy. But if you aren't well controlled, then you need to make some type of adjustment or figure out why they're not well controlled. And half the time it's because they're not taking the medicines or they're not taking them correctly. So that's where it comes into asking about med use and having them demonstrate how they use their meds. Okay, so the benchmarks about good asthma control, this is what we want people to attain. No coughing or wheezing, no shortness of breath, no waking up at night. You want them to be normal. You don't want to miss school or work. You don't want to have the parents have to miss or the caregivers have to miss because the kid is sick with asthma. So let's look at a couple case studies that go through this. This is one from last week, though, but maybe you weren't there. So there's a 3-year-old boy, lifelong history of, lifelong, wow, 3 years, of recurrent coughing. I'm an adult pulmonologist, so that's why I'm used to saying lifelong. But hey, for 3 years, he's had recurrent coughing. Recently seen in urgent care due to a severe cough, and was given oral steroids for 3 days and is getting better. Child is happy, playful in the room, and history is actually remarkable when you get further data that he's had several emergency room visits between 6 months and 18 months of age for, quote, bronchitis during the winter. So this is a pulmonologist's big red flag for probably this is asthma. It could just be that they had a viral syndrome and might have had a little wheezing, but several emergency room visits between this period of time is what your tip-off is. And actually, then you want to ask more questions. And she actually notes that the child has a daily cough, and she's given him albuterol. So the question is, what is your diagnosis? So just based on this history, you don't have spirometry, you don't have any other information. You have this story. The question is, what would your diagnosis be? And then what level of severity does this patient have? So you're already in the asthma teleclinic, so you're going to know that this patient's going to probably have asthma by this history. And so then what level of severity? So he has a daily cough and gives him albuterol often. It doesn't say how often, but a daily cough. So if you are going to go to the asthma classification, and this is for 0 to 4, he has daily cough. So we'll say symptoms daily. And cough is his marker for asthma, potentially. So you would say he's going to be at least a moderate persistent, just based on the daily symptoms. And giving a lot of albuterol. We didn't ask specifically how many times a week and how many times a day. If it's several times a day, then that was going to put him in a severe category. If she's given albuterol 3 or 4 times a day. Well, we don't know that specific thing, but we can say that he's having a daily cough, so he's probably going to be at least a moderate persistent. And he's had a few episodes in the ER requiring visits, and a recent steroid. So that would probably be how you would categorize that and say this child is a moderate persistent asthma. So then, if you're going to drop down below, you're going to go to step 3 or 4, and we'll talk about that, of what you were going to start this child on. So here's case 2. So it's a 17-year-old female patient, just returned home from first year of college, compliant with her long-term controller meds and denies nighttime symptoms. She's doing well, only having asthma symptoms if she forgets her medication prior to workout. She's using albuterol pre-exercise, really about 3 to 4 times a week, but is not requiring rescue medications, and she hasn't needed recent urgent care or prednisone therapy. So what do we think about her? So she has a diagnosis of asthma. It sounds like it's exercise-induced, and so otherwise, other than pre-treatment, she's not really needing anything. So what will we say her level of control is?
Should she be well controlled?
She would be well controlled, right? So because she's not really using it. Now here's the point I want to bring up. In this table, short-acting beta agonist use for symptom control, not prevention of exercise-induced bronchospasm. So that's what that not prevention of EIB means. Because if you were going to count the number of albuterol things she's using per week, you'd say, wow, she's probably not well controlled because she's doing it more than 2 days a week. Because she's exercising 3 to 4 times a week and using it pre-treatment. But because it's a pre-treatment thing and it's an exercise-related thing, and otherwise she's feeling fine, that doesn't count against her. So make sure that you, when you're asking them when they use their albuterol, if it is just pre-exercise, that's not a bad strike. It's only when you're using it for symptom control. So she would be very well controlled. So you would say, yay, I've done a great job. Keep up the good work. And then you would eventually, see her back as you would, as she would when she comes back for summer breaks. And I see these patients all the time. They come back for their summer break, check up, make sure I'm doing well, and then they go off to college again. So I probably wouldn't change much of her treatment plan because she's well controlled. I might decide to bring down some of her therapy if I knew what her therapy was. But this is not the point of this patient, but you can always adjust things if they're doing very well that you want to decrease. And here is on this table also that validated questionnaire. So there are questionnaires that kind of get at the idea of these symptoms. And depending on what their scores are, you can suggest whether the patient is controlled or not well controlled. And what we use is the asthma control test in our clinic, and it's a 5-question test that basically will answer these questions of how often are you waking up at night. I don't have an example of it, but it's asthmacontroltest.org. You can use that as a tool to help you get an idea of what their symptoms are. Good. Case 3. So here's an
Michelle?
Yes.
Can I ask a question about the asthma control test?
Yes.
So if you use any of the others, are they categorized the same as well-controlled, not well-controlled, or poorly controlled? Do they all use those same?
Well, they do have like scores, scoring. So the asthma, let's see. Asthma, yeah, it's in there, but I'm just trying to think, what is asthma ATAC? Asthma treatment, something control. I can't remember. But their scores are here. So there's 3 different questionnaires that have been validated, and depending on what their score is, you could categorize them as a well-controlled, not well-controlled, although the ACQ doesn't really separate out between very poorly controlled and not well controlled. It's either you're controlled or you're not. I use the asthma control test because it's the easiest. But again, it's subject to the patient's answering it, and that's why it's just a tool. It's not a perfect thing. So for example, it asks over the last 4 weeks, how many times have you been limited by getting any work done or school things or doing the things you want to do? How many times have you woken up at night? And so it'll grade it on a scale of 1 to 5. And the best score you can get is 25. But if it's 19 or less, then you're probably not well controlled. And so that's when you need to ask more questions, because sometimes patients are like, oh yeah, I am so short of breath I can't do anything. Well, and it's a nasal allergy or something, and they can't breathe through their nose, but it's not really an asthma issue. got to treat the nasal symptoms because that may promote some lower airway issues later. But it's a point of discussion. But I don't use the other things, and there are tons of others. Mini asthma quality of life. There's all kinds of other things that have been used in research studies to talk about getting a sense of how patients are impacted by asthma. So good question.
And are they all validated to the same age ranges? So ACT is valid
down to 4.
Above 4?
The others, I don't know if they are adult or children, honestly. But the asthma control test, and again, it's the easiest. And it's for the children, they have little smiley faces and frowny faces. So the child answers a few questions and the caregiver answers a few questions. And I imagine in the peds group, you sometimes see a discordance there, maybe.
Yes.
Would you like to comment on that?
Well, you do. I mean, sometimes the kids don't really understand the question. Sometimes the parents don't understand the question. And actually, if you look at the original data for the asthma control test in 12 and over, the population was skewed to people that were better educated, which is an issue, I think. Because when I go back over the questions for some people, they're like, oh, I didn't know what that meant. Nighttime awakening from asthma. Sometimes people are just like any nighttime awakening, where you're just like, that's not what exactly, it means.
Yeah.
Some people don't know because it asks rescue medicine use. Some people don't know that albuterol is called a rescue medicine, even though we educate them in those type of things. They still don't know. They know it by color.
Or point to what it is.
Yeah.
Right, so that's why it's just, it's a tool.
It's a tool.
That I sometimes change the score based on when I've asked them the question. And in the adult patient, how many times are you waking up? And is it because they have to go to the bathroom? Because they got woken up by someone snoring? Or because, there are a variety of things. So you want to make sure that it is a true asthma awakening. And that's the only one I have used. And you're right, it's in multiple languages, at least. Also, so we have them fill them out in Spanish and Vietnamese, and of course in English in our population that we see in clinic.
Dr. Morales, if you have patients that are under 4 or under, how do you document the asthma control?
You ask them the same questions. There's not like an asthma control test that we use, but you ask them the same questions. Because again, if you go back to the chart that has, your impairment and risk, and you look at symptoms, nighttime awakenings, and all that stuff, you ask parents what kind, how often are they having symptoms, how often are they having nighttime awakenings, those type of things, and from that you categorize it. Are they well controlled, not well controlled, or poorly controlled? But we don't have a validated questionnaire in that particular age group, so we just ask the questions.
And that's, again, you've probably gotten the hint that the control questions and severity questions are exactly the same, except for the questionnaire, because that's a specific control test questionnaire. But so trying to figure out what their symptom burden is, how impaired they are, and then, how often they're taking meds or how often they're being given meds can kind of help you sort out if they're controlled or not. And if they're giving meds, why are they giving the meds? In the adult population, it's I'm taking it 4 times a day because that's what it says to do.
Yes.
Or every 4 hours because that's what it says. No, it says every 4 hours as needed for wheezing. So you may not need to give something every 4 hours, a control med. And so that kind of counts against them, but they didn't really need it potentially. So asking them when they take it, what are their symptoms when they're taking it, and knowing if it's appropriate or not. So case 3, this is an 8-year-old being evaluated in the office for asthma. Very few symptoms during the winter, but in the spring, when her allergies are severe, look out. She has at least 3 doctor visits, 2 bursts of oral steroids due to nighttime cough and wheezing, and when she's wheezing when she's playing outdoor soccer. In fact, she doesn't even complete half of her games in May because she has such problems. It's now the beginning of the school year. Her parents bring in the forms for you to sign for albuterol at school. She has no symptoms in the past month. She's able to run without difficulty. She has coughed only once a month at nighttime. And then she hasn't really used any albuterol since the last spring. So the school form asks you to classify her asthma. So this is something that we face frequently. So what do you think her level of control is at this very point in time. When she's bringing the school form, she has no symptoms, she's not used any albuterol. If you just could cut out this portion, you'd say, she's pretty well controlled because she's not having any symptoms. However, when she gets to the springtime, she starts to have more allergies and therefore has more lower airway symptoms. And it sounds like she's having asthma problems that are probably allergy triggered during this time of the year. And she can't even complete her games. So her current level of control at the moment you're seeing her is good. But in spring, it's going to end up probably being not well controlled because she's going to be having frequent cough. So this is the type of patient that I see as well, and I say, I'm going to pre-treat you, or when springtime comes, this is when you need to start your meds. Because otherwise you're going to end up having problems and you're not going to be able to play your games. And so we actually had a patient, a young woman that was presented a few years ago in this clinic, who's every October she started having problems that she would be hospitalized. And so we worked with the nurse practitioner that was seeing this patient in a school-based health center and said, okay, well, let's make sure she's actually on therapy for her asthma, and she's really taking her meds, and there was some allergy trigger as well. Let's make sure she's on all of her meds and very compliant starting in August. She didn't get hospitalized that year. She was able to do all of her activities. I think she was in the band, or there was some other sports thing that she was doing. And so you can really make an impact if you preemptively strike, is what I tell my patients. Because they're probably not going to take their meds year-round when they're feeling well anyway. So bargain with them and get them controlled prior to their bad season, or jump on top of it so that they don't get into trouble. So we would say she was well controlled, but in the springtime she's probably not well controlled with all of her symptoms. Is that clear? Because now we're going to move to appropriate asthma management. So long-term control and quick relief medications, and educating them on which is which is important. So the quick relief medications that we have, short-acting beta agonist or albuterol, there are several different companies that make them. They're in a different formulation now, so they're much more expensive than they used to be because of, quote, new drugs, end quote. There are inhaled anticholinergics, which don't have historically a strong background in asthma management, but that's making a comeback, if you will. I do use them occasionally in patients that are my adult patients that really get so jittery with their albuterol that they don't like to take it. And it does bronchodilate patients. I don't know, in the peds realm, do you use this as well?
Sometimes. Yeah, sometimes we will, and some people that for some reason respond to it, because occasionally, like, if we have somebody, they're like, we're not all the way responding to our albuterol, sometimes we'll try it. That's not really totally in keeping with the guidelines, because they typically say you can use it in the emergency room and not once they get admitted.
Right.
Sort of the guidelines. And then some of our kids that have some tracheomalacia, it may help with airway muscle tone. So if they have kind of a mixed picture of asthma and tracheomalacia, it may help. So.
Right, so it is a bronchodilator, but it's not our first line standard of care, but I have used it. And then systemic steroids, it takes about 4 to 6 hours, and that's a kind of considered a quick relief because you're treating exacerbation. But it's still a 4 to 6 hour window before they actually really take effect to help with anti-inflammation in a exacerbation. But the long-term controller medications, daily inhaled corticosteroids, are bolded because they're the first-line therapy. Leukotriene modifiers are a possibility, and then long-acting beta agonists are also a possibility, but you should never use these alone. So if you're going to use a long-acting inhaled beta agonist, always make sure it is in an inhaler that it also contains inhaled corticosteroids in an asthmatic. And the reason is they're going to take the long-acting beta agonist, and they're going to leave their inhaled steroid on the shelf, because they're going to actually feel better when they take their beta agonist, because they actually feel that they get bronchodilation, so it actually feels it works. The chromones, do you guys use them much?
No.
Yeah, I don't really use them. Every now and then, It was, of course, they had a metallic taste. They do help with exercise-induced bronchospasm, but they're not particularly popular, and we have better drugs. And methylxanthines are the theophylline. They are considered long-term control medications. They're bronchodilators. I just say no, but they're obviously a possibility. And then the combination meds. So when you put them together, inhaled steroid and long-acting beta agonists, like I mentioned. All right, so this is our steps. So once you figured out their severity, then you're going to figure out what step of treatment they're going to take. And it's basically intermittent asthma, so the less than 2, they just need a short-acting beta agonist as needed, not Q4 hours around the clock, not QID, just as needed. However, if you have someone that has an exacerbation, sometimes we do tell them to take a beta agonist a little bit more on a scheduled basis for 24 or 48 hours during treatment or post-treatment for an exacerbation. But in general, you're going to just tell them to use it as needed. Once you have persistent asthma, you're going to increase your medications depending on how severe the disease is. And that's where you go back to those tables and it kind of tells you step 3 therapy or step 2. And notice that the preferred is always inhaled corticosteroids. Step 2, so low dose inhaled corticosteroids, or you could use any of those other agents. Step 3, you're going to use either a low dose inhaled and a beta agonist. And some other type of combination, or you can just go to medium dose inhaled steroids. Probably no right or wrong answer. I think a combination product seems to work better for folks that, especially if they have nighttime awakenings and they're more symptomatic. Step 4, again, you're just moving up the dosing. Step 5, high dose inhaled steroid with long-acting beta agonists. Adding on other therapies. We don't have a lot of good data. And a lot of other drug classes. We add things together to hopefully see if we can improve their symptoms. And then you're going to assess their control after you started it. And this part on the other side is talking about stepping up the therapy if you need it, or stepping down if possible. And that's the part people forget. So if their asthma, say you see a patient, you've got them on therapy, and they're doing great. So one of those case studies, they're doing fine, no issues, they're on their controller meds, and if their asthma has been well controlled at least 3 months, it's possible to step down. So lowering the dose of inhaled corticosteroids or changing them from a combination product, if you can, just to inhaled steroids. I think that's a part sometimes we forget, and we just add more medicines on, but we forget to step back down if possible. But that's okay, because the patient's going to step down anyway. So, for example, here's a 10-year-old. He's got moderate persistent asthma, currently on his budesonide 180 BID. And so it comes in. This is step 2 therapy. He's coughing and wheezing 2 to 3 times a week. He's using his albuterol more frequently. His peak flows have dropped because she's following peak flows. And then because of all these increased symptoms, you're going to, 1, make sure he's actually taking his med. 2, make sure he's taking it correctly. 3, you're going to make sure that there's not something new in the environment that may be causing this, or assessing why he's having these symptoms. But you're probably going to step up his therapy because he's not very well controlled. So moving up on the steps, like we mentioned. So the follow-up patients should be scheduled for planned follow-up at periodic intervals to assess their asthma control and modify the treatment if needed. This is a priority message from the guidelines. Depending on how they're doing is how you're going to follow them up. So if I have someone I'm concerned about, I've just started therapy, I'd like to see them back in potentially 4 to 6 weeks or 6 to 8 weeks, depending on what their symptoms are. If they're well controlled and I know them, and I may see them in 3 months, I may see them in 6 months. It just depends on what their symptom control is. So inhaled steroids in children. So really, I want to just mention this because people, patients and parents sometimes have a lot of issues. So with inhaled steroids, and they're worried that it's going to cause big problems. But they are the most potent and most effective long-term anti-inflammatory available. Putting patients on inhaled steroids decreases the need for their quick relief meds. This is 1,000th of the dose of oral prednisone. So really, when you kind of put it in that type of framework, They're like, well, I just want to take my prednisone, 2 or 3 times a year because I can get better. Well, telling them how much prednisone or how much steroid they're really being exposed to with oral tablets or syrup is huge. And that's what causes growth retardation and all the systemic side effects. So telling them it's really a fraction of the dose. Long-term studies really have shown that they didn't really inhibit long-term growth inhibition. However, that's actually not true. And we know that from the CAMP data that the children that were on inhaled steroids were a little bit shorter at the end of the study. And we thought, well, they're going to go to their normal height. Not going to be a problem. Well, now they're all adults. And guess what? They actually are still a little short. But they're alive. 1.1 centimeter. So if you can tell them 1.1 centimeter growth retardation potentially, which really,
bigger
not much.
Bigger effect in females, but I guess you can't really.
Small price for breathing.
Yes, a small price to be alive, and teeny tiny differences. Not a huge difference. But so we used to say that it really had no effect. So well, there probably is a little effect, but that effect really is minor when you put it all together. Have the patients rinse their mouth out after using their inhaled steroids, and I used a valved holding chamber to deliver these meds so that you decrease the local side effects and therefore systemic absorption. So that's another thing to really work with the patients and families on, that maximizing the ability to minimize the risk of absorption. All right, so key point number 3. Asthma symptoms are variable, so they need to recognize the symptoms, and they need to be able to adjust their medications at home according to the written action plan. So every patient with asthma should have a written action plan. So the features of these asthma action plans, they want to help guide self-management. So the school nurse should have a copy. Written plans should be key to the symptoms and severity and control, and really tell you how to take their daily meds, what meds to take, how much to take, and when to take it. And then, if their symptoms change, how to adjust their medications and when to call you. So this is just an example of asthma action plans, typically divided in green, yellow, and red. For, green is I'm doing well, I'm having no symptoms, these are the medicines I take every day, and why, and how often. And then, as you start to develop symptoms, or some people use peak flows. And it can be either or you can have both on there. But really telling them what symptoms to look for, what they need to take, and how often, and when to call. And so you can see under the little yellow zone, this is typically when you're starting to have more asthma symptoms, and you should call the provider to make sure that there's not another plan of action that needs to be taken. And I usually say red, so okay, why didn't you call me in yellow? You're already in trouble. So you should have already called me. But there are patients that can go very quickly down this cascade of symptoms. So they need to have some type of guidance as to what to do, because they forget. Key point 4, we won't spend too much time in this, but good communications. And I mentioned we think we're excellent communicators, but we're not. So we can give them all the meds in the world, but if the patient doesn't take them, it's really not going to be helpful. And there's very good evidence that compliance is closely linked to good communication and patient education. So if you can get the patient to buy into it and know how to take them, their compliance is probably going to improve. And again, we feel like we're great, but patients don't think so. So this is a depressing slide. So this is medication adherence studies. So documented multiple times. These are just a couple studies looking at a meter dose inhaler and one looking at a steroid inhaler. And notice that the mother or the child report, I'm taking my med 80% of the time. But when you actually registered their weight and the raw dosing and adjusted dosing of the inhaler itself, only 43% of the time were they adhering to their meds. Another study showed that about really 40% of folks adhere to their long-term controller meds. So that's depressing from our standpoint, because we like to provide them with good meds, but if they're not going to take them, they're not going to take them. And realize that, and kind of work with them and bargain. And that's what I do, bargaining with patients as to, especially to ramp up their medications when it comes time for their allergy season or other times of the year. So less than 50%, and we cannot predict. We can flip a coin and not know who's going to be compliant. So here's my story I tell on myself every time. So I had an older patient with severe asthma, allergic rhinitis, the whole thing, lifelong. So he was on high-dose Advair, which is fluticasone and salmeterol, so the highest strength, twice a day. He was on nasal steroid spray for his allergies. He was on twice daily antihistamines for his allergies. He was on twice daily Montelukast, which is a leukotriene modifier for his asthma. Still having issues. Very symptomatic. It's like, oh my gosh, what am I going to do with this guy? So I decided the next step, which is on that very edge of the step therapy, is a sub-Q medication called Xolair. And it's an anti-IgE. So it's kind of my last-ditch effort. I'm going to give him this. Well, and I'm going to refer him to National Jewish because his asthma is so hard to control. And he would bring his meds in and he could show me how he takes them. So I write for this medication and it gets denied by the insurance company because why? He hasn't filled any inhaler or any asthma medication for a year. So call the pharmacy and make sure that they're actually taking their meds. So, and he was like, I would never lie to you, Dr. Harkins. I am taking my meds. This is how I do them. I mean, it was perfect. It was like he was reading a script. And so I, of course, believed him. And so we cannot predict, better than chance, who's going to be compliant. So really working with them and communicating well is really probably more important than prescribing the right medication. I mean, prescribing the right medication is important, but communicating well and providing the education is really, really important.
So patients lie.
Patients
Till proven
lie.
otherwise.
Over and over again.
Till proven otherwise.
That's what happened to us multiple times. And
Yeah.
we have this external prescription history that you can go into the computer with, and we'll be surprised by, well, you filled it in October, and now it's, whatever, April, and you haven't filled it and say that things are bad. It's like, okay.
So-
and swear up and down. I
Yeah.
swear I'm using it.
Of course.
Even when confronted with the truth.
Yeah. So it's unfortunate. So you just have to be a bit more of a detective. But patient education is really the key. So if you can teach them the basic facts about asthma. So what happens during an asthma attack, how much there's inflammation that narrows the airways, how much there's muscle hypertrophy and spasm that clamps down on the airways, and what happens during an attack, and what's the difference between normals and asthmatics. So teaching them the basic facts of asthma, teaching them the difference between long-term control meds that they have to take daily and that prevent the symptoms, and often this is because they reduce inflammation and they don't give quick relief, versus the quick relief meds or the albuterol or short-acting beta agonists that actually give airway relaxation. But they don't control the asthma. So they've got to know both long and quick relief medications. Teaching them the skills, so teaching them to take them correctly. So we have them do inhaler technique and demonstrate to the patient and show how they've done their medication and have them show you. So how do you use your inhaler? Show me how you use it. And a lot of times they're not using it correctly. And so just need a little tweaking to show them how. I do believe strongly in valved holding chambers, or spacers as the other patient word that we've used. And so using them and then using the medications appropriately with them. And then identifying and avoiding environmental triggers. So, the cat that sleeps on the pillow if you're allergic to the cat, or the parents that are smoking can be an airway irritant. So helping them to figure out in their environment how to avoid symptoms and worsening. And then self-monitoring. So have them figure out, how well am I controlled? Okay, I'm doing pretty well. I can actually do all my activities. I'm not coughing. I'm not wheezing. If it's prescribed, a peak expiratory flow measure can be helpful to help them monitor their symptoms as well. Recognizing early signs and symptoms of worsening asthma and using the written action plan to actually tell them what to do and how to do it and when to do it. And then, they can take daily actions to control their asthma and adjust their meds in response to signs of worsening. and when to call you. There are asthma educators that I would love to have everywhere, and my goal is to have them in every county minimum, and they can help reinforce, or if there's an MA in your clinic that you can work with on some aspects. I mean, every person in the clinic could actually have a role in helping the patients adhere to the treatment plan and assessing their control and making sure that they've got their meds, or identifying barriers that they don't have their meds, and other things in the environment. I frequently found that our asthma educator, they were much more honest with them than they were with me, because they want to please me. Yes, doctor, I'm doing everything that you ask, and they want to please me. But they're having the asthma educator go in, she goes, oh, well, did you know that they're smoking and they're doing this and they're actually not taking their meds because they have some financial issues this month? So, you know, having other people try to help you assess what the situation is key. And that's all I have. So are there questions or cases or anything anybody wants to talk about?
And anyone who hasn't said their name at this point, go ahead and say so.
Michael Lance, ABQ Health Partners.
Hello, this is Julie Fitzgerald from HMS in Lordsburg.
Welcome. Thanks.
Oida Katemsep at Rio Rancho.
Great. Thank you.
Oida.
All right. Okay. Any questions? Concerns? No? Clear as mud.
A question on this slide that you have here with the billing code to teach how to their inhaler use. Does it have to be done by a provider or a certified asthma educator to build this code?
Yeah, so, and Kathy, feel free to jump in. So typically, it should be an approved standardized education by a qualified provider. It doesn't have to be a physician provider, but this is what we're trying to get through with different insurance plans. So if they have a person that's a provider that's recognized by the plan, they could potentially bill under this code. And we're trying to work with all of the different managed care organizations to get this paid for and approved, but I think we're still working with them, correct, Kathy?
Yes, there are two. Blue Cross and Blue Shield does reimburse for this code, 98960, and Molina does, with conditions that you are qualified and if associated with an agency or are have gone through their provider application. Those two do.
So we're trying to get everybody on the same page. We run an asthma self-management education clinic that's with our respiratory therapists. So if they've gone to the ED for an asthma visit, the respiratory therapist will refer them to this clinic, and they're seen by our respiratory therapists that are now billing under this code, and it has worked. So they spend about an hour with the patient. They do spirometry, they do education and showing inhaler techniques, make an asthma action plan, go through, because they have a standardized way of going through all the points for education. And so our institution is now submitting billings for this. And again, like Kathy was mentioning, there's a few that are reimbursing for it. But they are also certified asthma educators. So, you know, they've undergone a set curriculum and a test and are specifically certified and qualified to do this standardized education.
And it's prescribed.
And it's prescribed, right. So we're trying to work on getting all the bugs for other insurance companies, or what are the ways you can do some billing, you know, to get reimbursed for your time. The other thing is we'll talk about coding and billing maybe a little bit more specifically as we continue through the year, but you can bill for time and asthma education as well. So, you know, that time billing might be a little bit more, I guess, easier to hit or document. But other questions? Thanks.
Michael, Lance and I had a discussion yesterday that I'd just like to maybe clarify with you, Dr. Harkins, and that is that it's about diagnosis coding and the diagnosis codes for various severity classifications. And we are understanding that there are not specific diagnosis codes for the different severity levels, and that is not in ICD-9 and perhaps will not also be in ICD-10.
I don't know if they're going to be in ICD-10. They are not in ICD-9, right? It's just this, or even, acute asthma exacerbations, really the same first three with a different little class 2. But I do not think there are specific codes for the asthma severity. But I honestly can't say in ICD-10. I don't think that they're going to be. But I don't know that specifically. We're now looking at switching the hospital over to ICD-10 soon, so that'll be.
I heard that there was going to be, but in ICD-10, but I don't know. We can look it up quickly.
Yeah. Dr. Morales will find the answer in minutes, seconds, but I don't. It's not in 9, and I don't know about 10, honestly.
So when you reconcile the treatment step with the severity and the control, do you just put in the 493 code and then you write in
right
the severity level and you say?
Yeah, I usually say, this, 40, well, I would say 45-year-old severe persistent asthma by symptoms or lung function, usually in kind of my assessment, so that it's been documented as what their severity has been, and then who presents for a routine follow-up and is actually very poorly controlled or is controlled based on our asthma control test and symptoms.
It looks like ICD-10 does have categories for it. There are these J codes. Yes, they're split up into, they called it mild intermittent. Shame on them. Intermittent asthma, mild persistent, moderate persistent, severe persistent, and they're J codes, J45 point something or other.
Yeah, I'm not familiar with 10. I don't want to be, but I guess I'll have to be.
Yeah.
Could you, is that just a website that you went to, Dr. Morales, or?
Yeah. Yes, and it's actually kind of a nice website to look at if you're looking for codes for different things. If you have a question about a code, you pop it up.
The website is.
Do you think you could, would you be able to send me that link so I can share that?
Link. Yeah.
With the J and the J codes.
Yeah, so I don't know what the implication of that is going to be, though. Let's see, Q&A. Now there's another website here.
And documenting control and classification of severity is important so that you correlate with the right step in the stepwise management. But does it have any impact on your complexity of your patient when you go to bill?
Oh, I don't know the answer to that. I mean, I think.
Okay.
Because you make the assessment severity just once, and then
you make your assessment right, and then control yay or nay. I mean, I think it depends. If you're billing by time, it probably is not going to make any difference. But if you're the other E&M coding, they will give you so many points for your complex decisions that you made. So if you said poorly controlled and you're really altering their therapy and how this and that, I mean, but that was under the other E&M coding of when it wasn't time-based, it was, the X number of things and the history.
Complexity-based?
The complexity-based. So you would have to really really put down their poorly controlled, so therefore I'm increasing their therapy to X, I'm adding this, and we're doing this. And that would maybe increase your complexity component if you got all the other components of the exam and other in as well. But I think most people, I don't know, a lot of people go off of time because it's a little easier to do rather than making sure you got X components of your review system and X components of your exam and had a very complex interaction.
So it does look like, because there's this, I found another coding website where somebody's asking about coding for asthma. And what they've changed is now they have this difference between extrinsic and intrinsic asthma.
Oh.
They combine it all into one asthma, but they
okay.
want to know the severity. And it's these J45 series codes. So it's interesting.
And what is that website?
One of them is just like a HC Pro website, and the other one is ICD-10data.com. Let me see. Yeah.
Okay,
Yeah.
so the answer is currently there is not a distinction by codes,
Right.
but there will be J codes that go along with severity classifications in ICD-10.
Yes.
Seems like
Looks like
Seems
it.
like that's going to be the case.
Unless somebody decided to change it within the recent. I don't know. Yeah.
All right, thank you. Other questions? No?
I had one other question, and that was I've had one question expressing concern that patients did not keep up their albuterol schedule after a viral infection. And I remember that you had said as you were going through stepwise management that you sometimes will prescribe albuterol on a scheduled basis for up to 48 hours, but not often past that time frame. And I wanted to check and see if there are exceptions to that, like post-viral infections, or do you, do you usually not do it after 2 days?
At least for pediatric studies, we usually do it for 48 hours. We tell them to use it every 4 to 6 hours, 4 times a day, while they're on prednisone, especially because then prednisone and albuterol work synergistically together. So we definitely recommend that. But if they don't use it and they just use it PRN, that's okay too. There isn't really any clinical data to say if one works better than the other. But especially with pediatric population, we just want to make sure they use the albuterol. And again, just because it works great with prednisone, we want them to have both on board. But again, there is no data. But for all of our trials, even we recommend that for the first 48 hours to use albuterol regularly. And that is something that we put in the action plan for pediatric patients as well.
And that's in ours too as adults. Once you get that yellow zone, and if your peak flow or your symptoms have gotten worse, then we do recommend, you're doing X number of albuterol for, Q4 to 6 hours for, several treatments up to 48 hours, and then please give us a call so we can direct it more, because some patients may need to use it more often, but others may not need to. And the thing though, I don't do just a standing take your albuterol Q4 hours period. It's got to be associated with a kind of an exacerbation, period. And if people need it a little longer, or they need it just as needed after that, then that's fine, of course, too. But I don't do a lot of, there's the whole question of tolerance and other issues. So I don't do a standing albuterol just because, unless it's a exacerbation for a 48-hour window.
Thank you.
All righty, thank you. We'll convene in the second, no wait, this is the first, so it's in 2 weeks. Okay?
On the 22nd.
22nd.
Thank you all for joining us.